Thanks, Jess. Good morning. My name is Brenda Schaefer-Pellinan. My pronouns are she and her. By way of physical description, I am a middle-aged Caucasian cisgender woman with an auburn pixie cut, and wearing a gray sweater today. And I am joined by my colleague, Jess Langer, with the Arrowhead Area Agency on Aging, who will be managing our technology and our chat today. We would like to welcome and thank you for joining us for today's session on sexual violence in older adults. So before we start, next slide, we're going to go through a few housekeeping items. We have arranged for American Sign Language interpreters who will be present throughout the session. Those interpreters will rotate, ensuring that everyone can follow the content effectively. Recordings of today's session will be available on our YouTube channel for later viewing, and that will be with ASL interpretation. So whatever your needs, you're able to follow the content in whatever way you need to. We do encourage you to subscribe to our channel so that you can keep up with the latest additions to our video library. We are always looking for topics for future webinars, so if you do have suggestions for topics or speakers, please feel free to send those in an email to us and we'll share that in the chat. Please keep your microphone set to mute. Just a note, if you do experience any issues with bandwidth or audio quality, it often helps to disable your camera. If you'd like, you can enter your first name and organization or community that you're from in the chat and what you hope to get out of today's session. If you have any questions during today's session, please feel free to enter your questions into the chat and we'll address those at the end of the presentation, and we'll also take some additional questions at that time. At the close of our session, you will see a quick evaluation of today's session pop up in your browser. Please take a moment to complete that. It does help us when planning our future sessions. One last reminder, you can visit our Facebook channel or Facebook page for information about other upcoming sessions, such as our February session on managing money, Caregiver's Guide to Finances, and our March session on mental health and aging, thriving through life's later stages. You can also check out our website at arrowheadaging.org. Next slide. Just a little bit about the Arrowhead Area Agency on Aging. We are the Arrowhead Area Agency on Aging and the Arrowhead Regional Development Commission are designated by the Minnesota Board on Aging as the Area Agency on Aging for planning and service area under the authority of the Title III of the Older Americans Act. Here in Minnesota, we have 7 AAAs across the state that are local connections to older Minnesotans and community supports they might need as they age. The Arrowhead Area Agency on Aging, our planning service area, is designated by the Minnesota Board on Aging and includes the following counties: Aiken, Carlton, Cook, Itasca, Koochiching, Lake, and St. Louis. The Arrowhead Area Agency on Aging is committed to helping older adults maintain their highest level of independence. Area agencies on aging are regional organizations that provide the services, supports, and information for just about everything that older adults and their families could need. Next page. I'd just like to take a moment to read our land acknowledgement. As we support our mission to help older adults maintain their highest level of independence, we do this while being respectful of the space we are being welcomed into by Indigenous people. We strive to deepen our understanding of the multiple ways in which people see and understand land, and acknowledge the Indigenous people who have relationships with this land. We also acknowledge the decades of historical trauma, loss, and grief experienced by Indigenous people. It is our promise to not only recognize these truths, but take action to show support of our Indigenous elders, neighbors, and friends, and understand our place within the past, present, and future of this land. We know that this is just one step in recognizing and honoring the sovereignty of tribal nations. Next slide. Now I am pleased to introduce our presenter for today, Cameron Eidensching-Zeibel, a community advocate with PAVSA, the program for aid to victims of sexual assault. Cameron brings a unique perspective to this work, combining his academic background in philosophy with applied ethics from UMD, with hands-on experience in healthcare, where he witnessed firsthand how trauma impacts health outcomes. As an advocate, Cameron works directly with survivors of sexual violence, serving as a support person to help them navigate trauma and difficult situations on their path to healing and flourishing. Today's presentation addresses a critical but often overlooked intersection, sexual violence as it affects older adults. This topic challenges us to confront ageist assumptions while learning practical, trauma-informed approaches to recognition, response, and prevention. Cameron, thank you so much for being here today and sharing your expertise on this vital topic, and I will turn things over to you.
Thank you. My name's Cameron Edensink-Ziebel. My pronouns are he, him. Audio description wise, I'm a white guy with a red mullet and red beard. Um, I'm PAVSA's community advocate. PAVSA is a rape crisis center that primarily covers southern St. Louis County. And today I will be doing a presentation for you all on the intersection of sexual violence in older adults. Thank you for attending and listening to me speak on such an important topic. And thank you to the Arrowhead Area Agency on Aging for having me. Prefacing the presentation, I'd like to say what I say should be likely applicable to everyone in the human services fields that are working with older adults as well. But the research I was able to find on the topic is largely orientated towards those working in healthcare. So that's why I phrase it the way I do in the presentation. Where it's sensible to do so, just substitute your profession with healthcare. Which I guess a big thing too is that human services is doing healthcare largely for a lot of things other than just purely biological. It's still falling under the umbrella of healthcare. We like to start presentations by saying, due to the difficult nature of and difficult topic of sexual violence and the potential to trigger folks that have experienced it, we like to start a presentation saying sexual violence is an intense topic. Please do what you need to do and feel you need to do to take care of yourself during the presentation, whether it's fidgeting, leaving, what have you, whatever you need to do. Today, I'm hoping to provide an understanding of what sexual violence is, its pervasiveness, and how it can affect folks. Introduce what trauma-informed care is, and hopefully have enough information for you to implement it in your practices if you don't already. And I'd like also to share a lot on the state of research on the intersection of sexual violence in the elderly and what that research itself says, as well as talking about the challenges and barriers folks have to disclosing and also reporting for older adult survivors, as well as potential signs of abuse, and then kind of end on some prevention strategies in a way that individuals and organizations can aid in the flourishing of older adults when it comes to healing from sexual violence. I want to start off also by stating the simple fact that every human being has the capacity to be or is a sexual being. I have asterisks there because there are people that are asexual. However, it's a small minority of the population. Off the top of my head, I think it's less than 2% or around there. But that is all to say, you can't just assume someone is asexual because they are older. The idea that older folks are not sexual beings is ageist and often sexist as well. A large part of sexual violence work is addressing these incorrect assumptions in an effort to change the cultural assumptions at large so that more prevention work can be done. Reiterating, being old and experiencing sexual assault can and does happen despite not yet being a reality in the minds of mainstream society. I want to go over what consent is, particularly because it's important to cover in the field of sexual violence prevention, but it is to actively and willingly participate in an activity without coercion or force. It can specifically only happen when everyone involved has equal power, knows what's being asked, is on board with what's occurring, and is actively and enthusiastically participating. That is to say, there is an active seeking of yes to things instead of an assumed consent, or things being done without the yes, but also without a no. Importantly, with consent, no one is tricked, no one is being lied to or forced or threatened. Sexual violence itself is an act in which one is forced, tricked, or coerced and manipulated into doing a sexual act. Anytime sexual acts are used to gain power and control, it's sexual and violence. And it's also important to note that while sexual violence is an act of violence, it is not always physical violence. Often emotional violence and manipulation are key aspects of what folks experience. Sexual violence itself is an umbrella term, and a lot of different things fall underneath that umbrella, but I will just kind of cover some of the larger things briefly. Sexual harassment, which is any unwanted sexual attention or activity, whether it's verbal, physical, or electronic, in which someone is unwillingly subjected to or exposed to touching, grabbing, sexual jokes or comments, unwanted advances, gender-based discrimination, through language, or anything sexual in nature that the person did not consent to. Um, Straightforwardly, child sexual abuse is a type of sexual violence. Intimate partner violence, which is violence that occurs within the context of a relationship, is also a type of sexual violence. Any sort of unwanted sexual contact is sexual violence as well. Sex trafficking, which is a type of commercial sexual exploitation that involves the prostitution of an individual in which a third party, like a trafficker or exploiter, benefits. Um, and that's pretty much exactly what the Minnesota statute says. Sexual exploitation occurs when someone exchanges sex for anything of value or a promise of something of value, such as money, drugs, food, shelter, rent, or higher status in a gang or group. Another person may not necessarily be involved in arranging this exchange. A lot of what we see is survival sex, particularly, which is people having sex to simply continue living or have any sort of stability, which could be like trading for housing, money, drugs, to be left alone by someone. Sextortion also falls under sexual exploitation. It is the act of extorting or exploiting another person online for sexually explicit photos without their consent or knowledge of distribution. This is super common with children and older adults who are not as educated on internet safety or use different apps without knowing that images they send or things they send can be shared with others or used against them to demand more. Often it's the threat of distributing the photos to friends or family, and demanding more specific photos or money or something along those lines for the exploiter's silence. And then rape and sexual assault are straightforwardly instances of sexual violence. Going over general population stats here, about 1 in 3 women and 1 in 6 men is what most institutions or roundabouts there posit, is the rate of experience of sexual violence. It is significantly higher for folks who are gender nonconforming or non-binary. And that's just experience of sexual violence over the course of their life. The 2025 statistics from RAIN are every 74 seconds, someone in the US is sexually assaulted. They also find that 51% of female identifying victims of rape report being raped by an intimate partner, 41% by an acquaintance, 52% of male identifying victims report being raped by an acquaintance, and 15% by a stranger. Overall, different places have similar numbers of either putting it at 7 or 8 out of 10 cases of sexual assault where the victim knew the perpetrator, with knowing meaning they knew them for more than 24 hours. The data on perpetrating parties overall, according to RAIN, are 31% are done by strangers, about 28 by acquaintances, 21 by current or former intimate partners, 13% by relatives, almost 4% by an unknown number of perpetrators, and like 2.5% by an unknown relationship where the survivor can't remember. Age-wise, about 15% of sexual assault victims are between the ages of 12 to 17 when it occurs. 54% are between the ages of 18 to 34. 28% are between 35 and 64. And around 3% are over the age of 65. When I talk about older adults in this presentation, I'm talking about that demographic of 65 plus. However, overall stats when it comes to sexual violence are largely under what the actual occurrence is, because many people don't report or share that they've experienced sexual violence because there are just so many barriers to coming forwards or disclosing. I'd also like to squash the idea early that folks, quote unquote, make it up. While false reports do happen, the rate is generally put between 2 and 8%. And the occurrence is so minimal in the larger picture that it doesn't warrant not believing when people disclose sexual violence to you. Um, Particularly, uh, sexual violence against the elderly is underreported and not really researched. Um, I spent many hours looking for sorry, let me try this again, for journal articles and research, and there simply isn't a whole lot. There's a few handfuls of articles I was able to find about specifically looking at this topic, and they were really only primarily within this last decade. Um, there's like practically no research coming out of the United States, and research that does exist worldwide is fairly limited. It primarily only looks at cisgendered white women or occurs in places where there's not a lot of racial or cultural diversity. Most of the research also largely relies upon looking at people that live in communities such as assisted living or nursing homes. Um, I found a few articles that looked at independent folks, but only under the lens of prevention work. It is also worth mentioning that what little research there is does not really spend time or effort looking at older folks' support needs, what they are, or the effectiveness of treatment or responses of or by professionals following the experience of sexual violence. There's an article that or two that spends time looking at these topics, but since there isn't much other work, it's difficult to say that their answers are for sure definitive. What we do know from these studies is that older women who have received lower levels of education, which is to say, haven't pursued higher education or had dropped out of school, and that come from lower income backgrounds have higher victimization rates. Generally speaking, the more marginal a background or community a person comes from, the more likely they are to have experienced sexual violence in their life. So that assertion makes sense. We also find in the research that single female and widowed or divorced folks experienced abuse at significantly higher rates than men. In community, women in their 60s and 70s reported higher rates of mistreatment. In facilities, those in their 80s. It's also important to note that around 52% of people over the age of 65 have a disability. I say this because folks with disabilities are statistically more likely to be victims of crimes, including domestic violence and sexual violence. A 2013 study said that of those who had experienced abuse, most had experienced it on more than 20 occasions. Um, the Bureau of Justice put out a report that said the rate of victimization against people with disabilities is about 4 times that versus people without. And people with intellectual or developmental disabilities are 7 times as likely to experience sexual assault. And people that have multiple disabilities have the highest rates of abuse. Um, Various studies put the percentage of folks with intellectual or developmental disabilities who are survivors of sexual violence between 50 and 90%, with the most commonly cited stat being 83% of women with disabilities and 32% of men. Um, there's no numbers for folks that are gender nonconforming or non-binary, and I think that's unfortunate. And it also points just to the need of needing to have more research. Um, it's said that over half the people with disabilities that have experienced sexual violence have experienced it more than 10 times. So particularly when looking to older populations that have disabilities, it's something to be aware of, that it's just so rife. Um, A 2022 study found that 60% of older sexual violence victims never disclosed to their informal network, which could be their friends, their family, staff, etc., and 94% never sought professional help. I'll talk more later on barriers um, but suffice to say the vast majority of cases go unreported and unaddressed. And finally, from this slide, case analysis study covered by Norma's project, which was a project in Australia that specifically looked at the issue of sexual violence and um, the victimization of older adults, found that in an analysis of 20 people who were sexually assaulted, most of them who were under 70 but over the age of 65, indicated that over half of them died within a year of the assault. It's found that in general, medical literature indicates that sexual assault in older women results in a decrease in quality and length of life. Um, there, I think, without saying, or obviously, sexual violence is a traumatic event. It's a traumatic thing and has lasting impacts on survivors and the people around them. Here, I'll just kind of go over a little bit of the common experiences of folks, common in quotations, um, of folks who have experienced sexual violence, but particularly sexual assault. The common in quotes is because in reality, there's no common response. Um, Everyone responds differently. And just if you look at the slide, you can see there's just many different possibilities of things that people report. This doesn't even cover all of them. Um, Everyone has different ways of reacting and coping with trauma. So everything is normal. And in that sense, there's no truly right reaction. Um, I'm not going to read over them just because I timed myself yesterday and the presentation went a little longer than I liked. But um, big ones that you can see are depression or anxiety, um, self-blame, low self-esteem, isolation, suicidality, so on and so forth, avoidance of different things or dissociation. In terms of powerlessness, I think that makes a lot of feeling powerless. It makes a lot of sense because their autonomy was taken from them. Um, but there's also many of these experiences persist long term, um, particularly those associated with mental health. Um, from a 2022 paper, I've got a quote which says, when it comes to sexual violence, most studies on the elderly focus on long-term mental health outcomes of child sexual abuse and indicate that child sexual abuse survivors often suffer from internalizing disorders late in later life. End quote. Um, Different symptom clusters may also exist between younger and older adults with PTSD, which is post-traumatic stress disorder. Um, with older adults reporting more somatic and affective complaints. Lifetime sexual violence victimization is associated with PTSD in older adults with a chronic illness or disability as well. Otherwise, common long-term mental health diagnoses post experience of sexual violence would be major depression, general anxiety disorders, substance use disorders, eating disorders, sleep disorders. Many folks report nightmares or um, nightmares about their experience and other people's reactions to their disclosures. Um, Obsessive compulsive disorder, agoraphobia, or suicidal ideation. Um, this is not to say all of these would be present, but individuals may have some, none, or many of these diagnoses. Practitioners, according to a 2018 paper, felt as though the common experiences on the previous slide and these long-term mental health ones had amplified symptoms on older adults due to having fewer opportunities to draw on or develop supportive networks later in life. We also know from research that there are changes in brain structure and function after experiencing sexual violence, as traumatic events alter our brains. Memory issues are also very common long term, with survivors having difficulty remembering the order of events during a traumatic event, or even sometimes the event itself. It's a very, very common thing for survivors to have jumbled and nonlinear recounting of the event or events. There can also be significant physical health changes for survivors, particularly older individuals that experience it later in life. There may be long-term neurological damage, bone damage, brain damage itself, which can be particularly from choking or from violent rape itself. People can have complete behavioral changes as well. We have survivors come to us that refuse to ever work with men or women. Luckily, we have folks that of all genders, and we can accommodate that. But I think it's also a very common thing in society. You may see somebody when in the lens of the caring profession that just refuses to interact or work with anybody of a specific gender. It can completely change how a person interacts with others and how they go about their day, how they take care of themselves, etc. It alters relationships, social or otherwise, and can also lead to just disengagement from social organizations and institutions, that isolation long term. Um, Swapping gears more so to talk about trauma-informed care. It is a holistic care approach which aims at acknowledging the prevalence of trauma, evaluating or recognizing the effects of trauma on survivors, taking steps to address the trauma, and empowering survivors by providing professional support. It's not like a list of things that have to be checked off, but rather guiding principles that providers and staff can use to help trauma survivors experience a larger sense of security and safety. Remember that trauma from sexual violence is pervasive in the population, that it not only affects survivors, but also their families, communities, healthcare systems, providers themselves. And if you are work in a capacity of a primary care provider or so forth, you should know that also for any sort of providing of services, you should know that your own personal trauma history can affect and color your interactions with those you work with, particularly when discussing traumatic events. Secondary trauma, also known as vicarious trauma, can occur from discussing survivor trauma, sexual violence. Um, Keep in mind, speaking of like the signs, the effects on individuals, like what they could experience and the potential manifestations, but also know that not all signs of trauma are obvious or discernible. Having awareness that trauma has effects on survivors and providing a safe place on both a physical and emotional level are key tenets of trauma-informed care. On the personal level, responses to survivors can help draw on their strengths and promote healing, but negative reactions can re-traumatize. Organizationally, having policies which reflect trauma-informed principles and staff training to implement trauma-informed care can facilitate perceived positive responses that can lead to improved patient outcomes and disclosures. Um, when talking about like re-traumatization, we really want to resist and prevent it. Interactions in a healthcare environment or supportive living can re-trigger trauma and bring to front a sense of vulnerability, like examples of like undressing or laying down, being touched, simply being powerless. We want individuals to have control over their own choices of support, service options, and steps in their own journey towards healing. So simple things you can do if you work particularly in like a supportive living area and do cares, announce what you're doing before doing cares, making sure that they understand or are okay with it, allowing time for questions before and after procedures or things that you're doing, and explaining things as you go along. Um, Giving folks control over what services or procedures they utilize or access goes a long way. If they show distress, let them know that you can go at their pace or stop as much as is possible. Under no circumstances should you just be doing things without any sort of announcing or consent seeking, because that can be extremely triggering for folks that have experienced violence. Um, Although many older adults do not spontaneously disclose their sexual violence experiences to professionals over life, they are willing to break silence when asked about it. Having, particularly the research points to the healthcare industry add questionnaires and normalizing questions about sexual violence is really recommended by the research. The rationale being that healthcare workers or other frontline workers in those supportive settings have greater access to older adults and provide a valuable avenue to like uh, in which we as a society and as like systems can address sexual violence and help survivors to get aid and support. Um, that is to say, so long as you preface them with some framing, but also acknowledging and stopping if someone doesn't want to have that conversation, saying things like, if you aren't comfortable with answering or in a good place, can't handle these sorts of questions, that's absolutely okay. Say so, and we can move on and drop the subject. We don't want to re-traumatize and leave someone worse off than when they came to act you or to access services. It's also important to provide some framing for why you're asking questions so that they don't feel like they're being singled out and it's not normal in the context of caring for others to be asked about. Um, Starting the line of questioning with a framing along the lines of what, like the statistics that I said earlier about 1 in 3 or 1 in 6 have experienced. I ask all clients or about this because it can affect health. And so so that I can offer help if wanted. And mentioning like your environment and life experiences can affect your overall health. So we ask these questions during intake visits, et cetera, initialization of services. And then you can ask the questions um, along the lines of um, like, I scrolled too far up on my notes. I am so sorry. Um, like, have you ever experienced unwanted sexual contact, been forced, manipulated, tricked into doing non-consensual sex acts, um, been slapped, hit by a partner, performed sex acts in exchange for money, drugs, or food, shelter? If in the context of a relationship, does your partner demean or shame you or put you down? Or other kind of similar direct questions. Um, by normalizing these sorts of conversations and questions, we can help address the larger societal issue of sexual violence and provide care, or at least offer care resources to those who have experienced it. Research especially recommends that routine inquiry about sexual victimization be incorporated into the standard of care, particularly for older adults presenting with mental health problems. Um, so the goal of trauma-informed care is to empower folks who have experienced the horrors of sexual violence to feel like they can address the trauma and suffering they've endured in order to heal and flourish. Overall, facilitating that disclosure is largely reliant on trust. A number of studies point directly at creating an environment of safety and trust as being vital to making older adults feel both comfortable and able to disclose their experiences. When they feel like they're in such an environment and that they can anticipate trust and control over their stories, uh, studies point to them being more willing to disclose. So, like, utilizing active listening in these circumstances is super duper important. Um, just letting them know visually that that you are paying attention and then acknowledging what is being said to you, that or what they are saying to you. Um, it would be, I think, hopefully, obviously, incredibly invalidating to not respond or not pay attention. It would make them feel as though they and their trauma do not matter. Um, we also want to be non-judgmental because if people do not want to disclose, if they feel like they'll be judged for what they did not have control over, the individual should be able to feel like they can disclose without upending their whole life as much as possible. Keep what they would say in such an environment confidential. If you start getting near the territory of having to make a mandated report, be clear about what would constitute you needing to make a mandated report and let them know before it gets to that point so that if they feel like they don't want to or can't have that report happen, they can moderate what they share. Um, Despite everything, though, like even if you create this healthy environment, survivors may not be willing to share or disclose, and that's okay. What's important is that they themselves are in control. It's also good to know and share with them like what resources are available in your area to survivors of sexual violence or interpartner violence that empowers them with the ability to reach out on their own terms um, and just like letting people with capacity to reach out on their own is a super big important step that somebody can take on their own journey of healing. In general, like in order to avoid re-traumatizing survivors and to let the control of the situation be theirs, rape crisis centers don't generally reach out because family members or staff ask us to reach out to survivors. We want the survivors to reach out to us. Like secondary survivors, at least at PAVSA, so family members or staff, are more than able to access services with us and share information with the survivors. But if someone doesn't want to um, confront that, it is not okay to make them do that. Um, there can be like mitigating factors to like referrals, but like we really just truly want that contact to be survivor initiated. When someone does disclose, first and foremost, you want to respond empathetically, saying things like, it wasn't your fault that this happened, that this is the perpetrator that did it and nothing you did um, warranted it is just like such an important step. Um, a lot of survivors have a tendency to blame themselves for what they experienced. Um, could be due to like a very deep human desire to feel like we are in control of all things in our life, or feel like they should have noticed something was wrong, or many different thoughts. However, in no uncertain terms is it ever the fault of the survivor. Sexual violence is solely the fault of the perpetrator. So when responding to disclosures and the complex emotions that people talk about, remember to normalize such feelings. Let them know that feelings are common to people who have experienced similar things, or better yet, let them know that there's no normal reaction, and no reaction is abnormal. Providing validation, like, I'm glad that you told me that must, or like, that must have been really difficult. Um, Acknowledging statements like, thank you for sharing. I'm glad you trusted me enough to share with me. I'm so sorry this happened can go a long way. You want to avoid blaming them. You want to avoid questions that can be perceived as placing blame, like, what were you wearing? Why were you there? Why did you put yourself in an unsafe situation like that? Go into more detail in the next slide, but in essence, you never want to ignore or distract from a disclosure. And that was what victim blaming does. You should also let them know that help is available to them and that they are not alone. There are many safe places that can be connected, that they can be connected with to promote their healing or to help with healing. In that vein, you can offer them resources such as referrals to appropriate mental health agencies or rape crisis shelters, domestic violence shelters, etc. Um, Asking them, skipped ahead, uh, asking them like how you can help or what they would like you to do, or if they want your help, like what you could do to help them feel more comfortable, uh, can go a long ways in terms of just being there as a support person for them. Um, you can ask questions that help to promote resiliency, saying things like, what has given you strength in the past during difficult periods? Who in your life could be a strong support person that you could also share this with? But if you say that one, like, don't say it if they have told you they have no one in your life. That will obviously backfire. Um, but instead, you could ask like things like, what things or actions or thoughts give you hope or happiness? What things can you do? What things do you do to take care of yourself or others? Um, Particularly in situations of self-blame, I've found that asking survivors, um, if someone were in the situation, the same situation that you were or are in or had experienced, what would you say to them? Would you be as hard on them as you are on yourself? Adding that lens of a different person, can do a lot to shift their perspective and get folks out of difficult thought spirals of like self-criticism. You also want to be conscious of your body language, the tone of voice that you're showing as well. Um, Having open body language, a non-condescending tone, and especially not being flippant or joking in the situations either, can go a long ways to just having a healthy communication, but also just kind of promoting them feeling like they are being truly supported. Finally, you want to support them and support whatever they choose to do after an assault or disclosure. Um, don't support whatever someone else wants to do. What the survivor wants to do is of the greatest importance. It helps to reinstate control to them by respecting their decisions about their own body and story. And truly, like, the survivor knows what is best for their own well-being. Um, in terms of unhelpful responses, you shouldn't discount what they're saying to you, minimize what they're saying, or ignore them. It's also extremely inappropriate to talk about someone else's experience of violence or your own if you have experienced violence because they are opening up and sharing. And if you respond with that somebody else's or your own, it's invalidating to their own experience that they are trying to get out. Um, it takes away from their moment of sharing. You also shouldn't ask intrusive questions. Like, folks will share with you what they're comfortable with sharing. Asking them to get into gritty details and relive the experience is super re-traumatizing. Also, don't provide false hopes or reassurances either. People don't who don't work in the field will sometimes say things like, if you report, they will be charged and go to jail, when unfortunately that's not always the case. And it can get survivors' hopes up about legal system justice, but then that may never come. And when the perpetrator walks, it's incredibly painful and demoralizing. Also, don't try to fix the situation yourself. You're taking away from their autonomy and their choice, when they, of all people, need to be the ones to make those decisions. Don't interrupt their disclosure, make time and space for it because it's something incredibly difficult for folks to come forward and share. Um, Also, hopefully, goes without saying, don't defend the perpetrator. So many people have tried to come forward and tried to share what happened to them, but when people defend the perpetrator, it teaches them that it's not safe for them to share and that they aren't trusted by others. It's hurtful to their mental health, their flourishing, saying things like, they're a nice person. I just couldn't imagine them doing something like this is not good. Um, in the speech bubbles, you'll see some common unhelpful responses we've heard of folks telling survivors, um, like everything happens for a reason, or at least X, Y, or Z didn't happen. Well, why did you flirt with them? None of those are helpful or beneficial. It's just realistically either victim blaming or trying to minimize, and that's just not a good way to a trauma like be trauma informed or care for an individual. Um, you can just truly never tell a survivor enough times this was not your fault, and I believe you. It's pretty plain and simple. Um, in terms of if someone in later life experiences a sexual assault, what they can do is reach out to a support person. Um, could take the form of a friend, family member, advocate, or other trusted individual. They could call a crisis or helpline um, to get support, referral, or access to services. They could also go to the hospital and get a SANE exam, which is a sexual assault nurse examiner exam, um, which is like a forensic nursing exam done by nurses who are specifically trained to collect evidence and go through the exam. They're often several hours long and are very detailed. Um, but a person can choose when they get these done to either have a report to law enforcement made or to put it on hold and wait. Um, for us at PAVSA, we do them up to 14 days after an assault, but some facilities by protocol have shorter collection windows. Despite that, though, evidence collected at 14 days has still been used to convict. A person can make a report to law enforcement. Importantly, Minnesota has no statute of limitations on crimes. So um, that could be something that they choose to do that they might find solace and some healing in. But also a person could choose ultimately to either do all of the things or none of the things. It's up to each and every survivor what they want to pursue. And in my capacity as an advocate, my job to help them navigate that journey. I think it's briefly worth going over healthy relationships, particularly for folks who may be doing home visits or working with folks that have uh, relationships that are perhaps have set off some red flags or haven't. But looking at healthy relationships um, as opposed to red flags can be kind of beneficial. What we ideally want to see in a healthy relationship is, healthy and open communication where honesty and understanding are sought. If there's disagreement or any sort of verbal fight, it's not a belittling uh, fight. And viewpoints are shared and feelings are shared without attacking. Boundaries are respected and people's individuality is as well. When there's issues, they're resolved together instead of um, as opposed to each other. In terms of red flag, this isn't like an exhaustive list, but if you observe these when working with someone, it might warrant more thought on the relationship and the healthiness of it and talking with them about healthy relationships. Um, Love bombing, which is attempting to influence someone by intense demonstrations of attention or affection, is a method of manipulation, particularly early in relationships. Um, if they don't respect each other's boundaries, whether it's physical, emotional, or digital, or overly jealous to the point of not allowing independence or a lack of trust of their partner, that's unhealthy and not great. Um, Unhealthy communication, like demeaning, is not good either. Um, Something that can be seen as like constantly coming around if you're speaking with a partner or if someone is close to them as a way of like just watching and kind of being possessive. Um, Gaslighting is a big red flag in terms of like might be wrong. Um, Particularly, I think out of the list that I have up there, like the biggest red flag is if they have a possessive or controlling partner to the point where they're not allowed to talk to people alone, seek care alone, or be around other people. not only is it an indicator of toxic relationships, but it can be an indicator of worse things going on. As for example, a common thing we see is traffickers doing that. But it can also just indicate that someone is potentially abusing their partner and trying to protect themselves. Um, I think these kind of all kind of funnel into the idea of romance scams, which are common for older adults. Like a person may be constantly getting money or things from them, or they might not have education on healthy online behaviors or healthy online dating, and may be tricked by others in order to obtain more wealth or their possessions. So like if you notice things are going on or significant things are missing, I would say you should be concerned and try to provide education on safety and make sure the person knows what it's looks like to be taken advantage of without actually asserting that's what's going on. Asking questions instead of being direct with them, hopefully to get them to the realization of what they might not be experiencing or what they might be experiencing as unhealthy. Um, Following that is just potential signs of abuse. We can look back to the common experiences slide for a rough idea of things that can be, looked at as potential indicators or of abuse or having experienced sexual violence. Um, all these different things are common experiences, can be, if they're new or appear, can be, indicators, but like just generally like fear or avoidance of places or people, changes in appetite, particularly with like um, clients that maybe have cognitive deficits or disabilities, significant, sudden, or unusual changes in mood or behaviors can be an indicator that something may be wrong. Um, there may be increased bruising or cuts or incontinence. Uh, Clothing may be out of place. Injury to private areas or genitals. Um, like research suggests that like older women who are assaulted are much more prone to genital trauma than younger women. Um, but just like new pain. Like all of these can be like little signs that might be ignored by someone because some of these may be fairly common in older populations, particularly like bruising or incontinence, but they can also just be themselves signs that something maybe worse is going on. Um, I'm going to try to go quickly through this just in the interest of time. There's a lot of barriers to supporting and reporting. Like physically, exams might be difficult if they have difficult moving legs apart or relaxing limbs. Could be difficult getting to places to get exams done. Hearing and sight impairments can create barriers to accessing services. Um, if someone has a disability, their perpetrator might threaten usage of necessary equipment for daily living being taken away. Um, in terms of emotional barriers, they mirror those of younger individuals, such as a sense of shame or fear, anxiety, and so then blame. Emotional challenges are also magnified for some older individuals due to norms earlier in life, which serve to inhibit disclosure or discussion of sexual violence. Strong feelings of shame and self-blaming combined with internalized ageist ideas of therapeutic nihilism not only convinces older adults that they don't need help, but also that they don't deserve it because of their age. That is to say, like, there's this pervasive, unfortunate myth that treating traumatic experiences in late life is quote unquote not useful. In terms of dementia, there's the obvious problem that folks with dementia might not be believed when they disclose and get dismissed by folks with, that are carers or families or auditing bodies. And uh, like law enforcement might not necessarily believe them because of those cognitive deficits. Um, in terms of social and cultural barriers, there's quite a few, like being older and experiencing sexual assault, having not being been a reality for much of society. This like ages social construction that older folks are not sexual, that they are asexual, make it so clinicians, staff, workers may not recognize some of the signs of sexual abuse, particularly since older women are viewed as culturally unattractive and asexual, and then considered impossible targets. This serves to delegitimize acts of sexual violence against elders late later in life. Additionally, this used to be something that someone didn't just talk about. So they might not feel like comfortable sharing the information that's so sensitive and distressing, but particularly not so with younger folks. Um, there's also the norm of older adults tending to minimize their experiences as impacts. In terms of toxic masculinity, like men don't disclose until later in life, generally, largely due to social and cultural factors. Toxic masculinity, which is to say the fear of expressing emotions and trauma for male identified people, is unfortunately ever present, like men having being told or thinking like you could have fought them off, you're stronger than them, etc., can run through their heads or can prevent disclosures because it's invalidating. Um, there's also the stigma itself of being a male survivor. Sometimes people wrongly think that acts of sexual violence are about orientation or sexuality instead of being about power and control. Sometimes people also wrongly think that someone's orientation or sexuality is the result of a previous victimization, which just isn't true. Um, there's a lot of fears involved with being unwilling to disclose for older folks. There may be a fear of harming the assailant, particularly if they're family, um, fear of consequences themselves, to themselves, like maybe they'll be scorned or lose housing. They may depend on the perpetrator for care, so their current living situation, and would rather continue to experience it than be unhoused. They may be afraid of not being believed, or if they're isolated, it may be difficult to reach out to others. If someone's part of a community and harmed by a person with power or prestige in that community, they risk being ostracized and punished by others for speaking out and disclosing. This is particularly an issue in communities of disability or marginal or smaller communities. If someone's cognitive capacities have declined, it can make it difficult to recognize or report abuse, and they may be immediately discounted. The idea that no one will believe you can be propagated by the perpetrator and may be weaponized. There may have also just been simply a lack of sexual education when they were younger, particularly a lack of prevention education. They may not recognize non-consensual sexual violence within the context of marriage as um, their sexual assault or abuse, because it's like a patriarchal societal ideal. And those ideals were strictly enforced, if not by individuals, then by society themselves. Um, and they also just might not understand or know or have learned that what sexual violence is, and what they have experienced as sexual violence. Norma's project itself had a quote from a worker that specifically worked in the area of sexual abuse of older adults, which said, older women can struggle to name or identify their experience of abuse as sexual assault. Unless it was violent stranger rape or rape with violence that was involved the police or the hospital, older women usually talk to someone in a generic environment first and often need someone else to name that behavior and what they are or have experienced as rape. They might just think it's normal that it happens in the relationship. When someone can name it for them, they may be able to give themselves permission to acknowledge what it really is. Um, they also simply might not have had resources when they were younger and experienced sexual violence and might not know that there are those resources out there for those who have. Um, those attitudes towards disclosure or seeking professional assistance back then were negative, and it was common that they would be ridiculed or not believed. Um, Staff attitudes, if they live in community, if they appear to be untrustworthy or uncaring, cruel, a person will not be likely to disclose. But also numerous studies have pointed to underreporting by staff, sexual violence and sexual abuse of the elderly, and largely posit that to struggles in the ability to recognize abuse and respond appropriately. Um, I think a large barrier too is just people have a discomfort when talking about issues of sexual violence because it's a sad and upsetting topic, and folks often don't feel like they know what to do or say. So, in terms of like prevention stuff, just starting off by teaching about consent can be really helpful. Folks that go into houses or to observe or work with folks have the ability to observe best and see differences in behaviors or situations and can help to be avenues to pull a person aside, do some education or checking in to make sure that they're okay. Um, Having clear policies and procedures when it comes to sexual violence, that everyone is conditioned to react the same way. So if there isn't any moments of asking what we should do or what do we do as an organization, can be really beneficial in prevention work, in responding. Uh, having programs add longer modules and trainings on sexual violence so that workers are better able to recognize signs, but also provide that trauma-informed care when disclosed to, would really go a long way. Ideally, having like managers and staff that are supportive and an organization that's supportive, willing to address the difficult issues instead of pretending they didn't occur. Um, Having more capacity, which is to say, training folks and to feel more comfortable talking about sexual violence can go a long ways into addressing that and making people feel like they don't have to hold it within themselves until they pass, that they can share it and they don't have to just bottle it away. Um, Given the high occurrence of sexual violence in older adults in lifetime and in the last 12 months, just doing a routine inquiry about sexual violence victimization in older adults in healthcare settings would be really beneficial in normalizing those conversations. Um, it's important that support offered to survivors also uh, is informed, I guess, culturally speaking, is sensitive to the stigma associated with sexual abuse, but also with older age and nudity. That is to say, it is sometimes necessary to use words beyond rape, like sexual abuse, SV, or sexual violence, unwanted sex, forced sex, sex you didn't want to have, sexual harassment, etc. Um, Importantly, I think to mention here in best practice stuff is that 2022 study indicated that trauma therapy decreases symptoms of depression and PTSD in older sexual violence survivors, that therapy services is worthwhile, that it's never too late to seek help for someone, and that we shouldn't fall prey to therapeutic nihilism. Um, Providing resiliency and strong social supports has been shown to decrease the mental health impacts of victimization in folks, so encourage and invest in building those up. Addressing sexism, ageism, and paternalism in society also can go a long way to spreading awareness. Really close to time here, so I'm just going to go quick through here. In terms of reporting, if you're a healthcare worker or somebody that's a mandated reporter, call the Minnesota Adult Abuse Reporting Center. If you're not a mandated reporter, consult the individual, I suppose, that you're concerned about and get their input if they want that and if they have the capacity to determine that. Because we cover 7 counties, I've got a slide that has resources for each of the 7 counties. If you need the slide deck, feel free to email me for it. And then I got my works cited. At PAVSA, we provide free and confidential services from advocacy, legal advocacy, 24/7 hotline. We do all the medical exams in Two Harbors, Superior, Duluth, and recently Cloquet. We have support groups and a trafficking program, and we work with folks and survivors and people that know survivors of any gender, ages 13 and up. Thank you.
Thank you so much, Cameron, for a very comprehensive and really eye-opening presentation on sexual violence and older adults. Your expertise really provides us with some really essential knowledge about trauma-informed care, about the unique barriers that older survivors face, and practical strategies for really creating a safer, more supportive environment. For key takeaways from today include the critical importance of believing survivors, of implementing trauma-informed practices in our daily work, and recognizing that older adults are indeed sexual beings deserving of dignity, respect, and safety. We've learned how to better identify some potential signs of abuse, respond empathetically to disclosures, and connect folks with appropriate resources. For those who might need follow-up resources, please remember that PAVSA provides free and confidential services, including advocacy, counseling, legal support, and 24-hour crisis response. You can reach them at 218-726-1931. For mandated reporting in Minnesota, contact the Adult Abuse Reporting Center, or MARC, at 1-844-880-1574. A few quick reminders before we close for today. This webinar recording will be available on our website within the next week. Please don't hesitate to reach out to the Arrowhead Area Agency on Aging if you have questions about resources in our 7-county region. And we really encourage you to share what you've learned today with your colleagues and with your network. Thank you again, Cameron and PAVSA, for this important partnership. And thank you for all of our participants for taking time out of your day to learn with us. Your commitment to protecting and supporting older adults in our communities is really what makes a difference. And I just want to, if anyone has any questions before we sign off for the day, can either come off of chat or put them in the, or you can come off of mute, I should say, or put them in the chat. Not seeing any questions. Oh, we will have copies of the slides. We will generally send those out with our follow-up with the link to the recording. Anything else? Well, thank you again, Cameron, and everyone have a wonderful rest of your day. Thank you so much.